I guess now we have like 15 minutes or so left. There are a bunch of questions from the webinar. Everyone is free to hang out and while we answer them, or free to go. So we're going to do that. Nikki.
I just wanted to combine two of the things I've heard over the last 24 hours to sort of see if we can chip away at this notion of permanent muscle weakness. And one was the mention of someone getting cord blood transplant, and that brings stem cells along, and stem cells have the ability to go into certain tissues and repair and take over and sort of start again. And the other thing that made me think of this was this statistic about a lower rate of symptoms in females, because one of the things that's become increasingly apparent over the last 10, 15 years has been that many women have stem cells from many of their previous pregnancies, that are not only still in their body, but they're going around doing good deeds here and there, replacing things that were problems. And I wonder if people have any experiences in terms of what the effect has been of pregnancies, even including a pregnancy that just went 4 or 5 months and didn't get beyond that. Whether there's any stories that could be interpreted as possibly stem cells reversing weakness.
So is that a question or just a kind of general?
Well, I'm just throwing out as a possible notion that people might want to think about, but if anybody has any observations. I mean, obviously there could be things related to hormones, but lately it's become very clear that for instance, most women have some male cells that are genetically male in their brains,
right,
that are doing stuff in their brains, and they have lots in the liver. Who knows? There might be ones in the muscle.
Yeah, absolutely. No, it's an excellent hypothesis. Do you want to comment on that? Or? Okay, just because I want to get to the webinar questions too. But go ahead.
You said if anybody had any comments on it, just speak up. So my mother has always insisted that what I have is hormonal, because during pregnancy and afterwards was the best time I've ever had. So is that literally what you mean? That time period, or did I misunderstand?
Well, there's... I should go closer. There could be effects that could be hormonal, like estrogen and progesterone could have a direct effect on making it easier. But I'm raising the sort of more interesting therapeutic issue of, can you give somebody an injection of stem cells that would lodge in the muscles and grow muscle, and ideally grow muscle that doesn't have a paralysis problem, and give you the ability to overcome what would otherwise be permanent weakness. And it's hard to distinguish, I think, from the experience. If something happened just during pregnancy and then afterwards was, the effect went away like a month or two after the pregnancy, I would think more that that's hormonal. But if there was a period of years that you were better until something else happened, then I would wonder more about stem cells.
Great. Those kind of like larger thinking hypotheses that are kind of thinking towards strategies for real like cure kind of things, or the exciting things that we hope the top researchers are glomming onto. I want to give the mic to Grace and James and Frank.
Oh, just one question about or just one comment I should say about the stem cells. With mitochondrial diseases, group in New York and Columbia, DeMauro and colleagues have tested the idea of actually wiping out the muscle with powerful chemotherapy, and when it regenerates, it seems to regenerate with with an improved phenotype, so the mitochondria seem to work better. Now, I'm not suggesting that's an option for periodic paralysis, but these novel ideas may actually gain some traction over the next few years.
All right, so now we'll start with the webinar Q&A. The first question is, why do I have severe muscle pain all the time, even between attacks?
So we've got about 20 webinar questions here, so forgive us if we kind of give you a short answer for some of these, but there's a variety of reasons for muscle pain, obviously, that have to do with periodic paralysis and many other conditions that cause muscle pain that have nothing to do with periodic paralysis. So I think we probably need to know a bit more about the muscle pain in terms of what are the triggers, what makes it better, what makes it worse, is there muscle tenderness with that, what is the CK level, is the patient on a statin medication which might cause muscle pain. You know, a lot of other things can cause muscle pain. Low levels of vitamin D can cause myalgias, muscle pain. So probably need to know a little bit more about that before we gave some specific information about that, I think.
Yeah, and I would comment also that just a lot of patients with periodic paralysis do report muscle pain for whatever the etiology is. Is it periodic paralysis or some other factor? But that certainly appears to be something, and it's something that's not really addressed well in the literature in terms of a controlled way of what medications to suggest, short of like non-steroidal anti-inflammatory drugs.
Muscles often produce pain, and it is a common experience that persons with inherent muscle diseases experience muscle pain for which doctors not have a clear-cut explanation. For example, in myotonic dystrophy type 2 Ricketts disease, it's a problem that you find nearly intractable muscular pain, which can be treated by central anesthetics, but not by the ordinary treatment against muscle pain.
Yeah.
Yeah, in reference to the controlling of the pain, will they try to do something that will be without addictive drugs?
So and we'll
Because I have pain 24/7.
save the question. We're going to do the webinar stuff. After the webinar stuff, we can answer.
Okay, continuing with the webinar questions. Someone asked about the CMAP exercise test. If they've had one positive but 2 borderline results and a negative, do they have periodic paralysis?
So as I commented during my talk, the exercise test is an important part, but not necessarily, not the only part of the picture. It really depends on the clinical history, but assuming the clinical history is pretty good for PP, then one should be enough, provided it was done well. And as I showed in one of my cases, you can have a negative exercise test on one day and a positive one on another day. So if it's done well, then one should be enough.
Someone asked what I think of Pilates for periodic paralysis. I think Pilates is more likely to cause issues for people with periodic paralysis because it requires you to hold poses for long periods of time with a constant muscle contraction. So that's why I tend to side with yoga there, as it's more fluid but gentle, slow movements for the most part, while incorporating some muscular exercises. The next question was for Jake. Okay. Just as far as the Daranite study, what's the time frame and how long is until it's available, if you know?
Okay, so there was, and I'm not part of this, I don't know if you're part of the cinch aspect of dichlorphenamide. Dr. Griggs in Rochester was studying dichlorphenamide for periodic paralysis. Initially, the roadblock was getting the actual drug. Finally, we were able to get the drug through Taro Pharmaceuticals, and I'm not sure if the supply that he got from them expired or if they're still supporting that venture. And it may be that the Taro Pharmaceuticals decided to, I'm no longer with Taro Pharmaceuticals, that we got hostilely taken over and I was thrown out in 2010. So I'm not in control of that drug anymore. The long-term plan was to be in control of that drug and disseminate it. And anyway, I got thrown out just before it could happen. But the current management is not interested in pursuing that. So I don't know if he has drug, and that may be why the study isn't continuing. He also had a very difficult time recruiting patients, it may have been the study design or what. But so I guess I'm not really sure what's going on with that study.
If that person wants to email the question through, we could get an answer for that. I could email some colleagues at the U of R and get some updates on that.
This person wanted to know from Mickey, why does serum potassium lower after fluorescent light exposure?
This is something we haven't been talking about, but has come up on the listserv. There are certain people who seem like when they're exposed to electrical fields have symptoms of hypokalemic periodic paralysis. It seems like it's among the lidocaine insensitive group. It's something that, if you've seen any articles about sensitivity to electrical fields in the popular press, is sort of highly controversial in general for a whole variety of reasons. And it looks from working with a few of these families that this is real. Our feeling is, let's find the mutation first and have this in mutation-proven people, and then publish something about this phenomenon in mutation-proven people, because otherwise I don't think it'll get taken seriously. But I think this does exist, and it's going to make a real big fuss when this can be demonstrated with some solidity, and people would understand that some people can be affected by electrical fields. It has potentially huge implications in terms of a wired society, and it's something we plan to approach with caution.
Another question for you. A family wrote in with 6 generations of individuals with periodic paralysis, ADHD, and lidocaine insensitivity, and some combination in each generation. And Frank Lehmanhorn has their blood, and they want to know if he's testing it for new updates as you do in conjunction with your research.
Well, the work that I described on trying to find the gene for the lidocaine insensitive form, the genetics are being done by Dr. Lehmanhorn's group, and so this is the same effort. And he's working with several families doing this type of tracing to find this exact location. And so he has more families than he's used the DNA in a detailed way for, but the idea is to try to find the gene in some of the families where it's easiest mathematically to pinpoint what's going on, and then the idea will be to test the whole range of people and see, is this one gene, is this 2 genes, and so forth. I think it's very clear at this point there's a 3rd gene. There may be more, but he and Dr. Jurkat Roth are the ones who are the key people on doing the lab work to find the genes.
And one more for you. What are the prospects for gene replacement therapy for periodic paralysis?
I can speak more from the perspective of, I used to know more about this a year ago before I found out about some recent work. The notion was that this was a gain of function issue, and this dates back to some of my work on epilepsy, where what's going on in the SCN1A channel in epilepsy is that you have an increased number of openings, of late channel openings. In other words, it was originally believed back to the 1950s that sodium channels open quickly, shut quickly. That's what gives you the action potential, that gives you the the signaling in nerve cells. But going back even then, the scientists noticed there was this tiny persistent current, and they figured that they weren't getting a good, accurate recording. And it turned out that there really is a persistent current, and I, in fact, in this single nerve cell model of epilepsy that my group developed at Harvard, we were able to show at the single channel level that there were late openings of sodium channels that created this persistent current. And so the notion was very much that that you have this channel already. If you try to replace it with another gene, you still have this other gene there, and you're not going to be able to replace it. But there's some recent work with some of the sodium channel mutations that suggests that there are some situations where where what's happening is in some situations the other gene, the normal gene, isn't working well, and then you have this other one, and it may be that you can put another one in. And it's less clear. I feel less clear in saying that this won't work than I did a year ago based on some of this new work. But I would think that the major answer for a lot of these things is going to be to either dietary or drug things to modify the properties of the channel. But you still have this channel that's giving you this effect, and you can't get rid of it. It's just a question of whether you can add other things and modulate.
Okay. Yeah. I mean, I think also there's some interesting possibilities of small inhibitory mRNA. If you can decrease the expression of bad genes without necessarily snipping them out of the chromosomes, that's one theoretic possibility. So there is hope for genetic stuff, and then Dr. Steve Cannon is working on various mice that have periodic paralysis, where he replaces the good gene with the periodic paralysis gene, and then does all kinds of studies. And I'm sure that since there are animal models that are around, we can start to imagine working on these different issues.
So in terms of upcoming therapies that might be available, stem cell nuclei replace muscle cell nuclei. So if you have a normal cell nucleus in some kind of stem cell, you can actually use that as a treatment. You can take it out of the body, modify the gene, and then reintroduce it back into the body. Since muscle cell has multiple nuclei, then you're likely to create less of a paralytic effect. So you're not fighting the old genes. Another technique that would take place later is something called electroporation, where you can stick a synthetic genome into the cells itself. As Dr. Siegel was saying, you still are fighting the abnormal product at the same time. And since it's dominant, you could reduce, I would imagine, some of the effect, but it wouldn't be a cure. But the cell nuclei replacement therapy, that could actually be a cure in individual muscle tissues.
That's super exciting. That's actually very cool. It is, just by the way, just for time-wise, it is 5:07. Linda, when do they kick us out of here? Okay, 5:15 to 5:30. So let's do like one or two more, and then anything else. If guys in the audience, and there was a few people I had to shut down, I'm going to be here. I'll stay around the area for a little bit, as well as the other doctors.
So some individuals noted that they know periodic paralysis affects their skeletal muscle, but it seems to them that they have...
Sorry.
Hello? Hello?
Yeah?
I think it's good. So they feel so also the periodic paralysis affects their breathing, heart rhythm, and sometimes ability to urinate. So is there an effect of periodic paralysis on the smooth muscle as well?
Yeah, there are obviously patients who suffer on the smooth muscle involvement, especially in the wear diseases, in the wear attacks. Yeah.
is a ketogenic diet beneficial for hypokalemic periodic paralysis?
We don't know. Simple answer is we don't know. It's a very, very hard thing to maintain, and mostly used for children with severe refractory forms of epilepsy, in which case they have nurses that specifically are involved in keeping that ketogenic diet going. So it is maybe an easy thing to start. It's quite a hard thing to keep going. I guess the modified Atkins diet might be another slightly easier thing, where you basically cut out the carbs and increase the fat. I guess that in itself would have inherent attraction in periodic paralysis, hypokalemic particularly, by cutting out the carbs. But I can't make any other comment other than that. But I guess I would say that ketogenic diet is very difficult to maintain.
So we'll do one more, I think.
Okay. Well, one was what common medications affect potassium levels. So a couple I'm aware of is with, you can get elevation in potassium levels with beta blockers, with digoxin, with non-steroidal anti-inflammatory drugs, heparin and Bactrim, or trimethoprim, an antibiotic. And as far as a decrease in the potassium, diuretics, of course, laxatives, as we talked about, and corticosteroids can decrease your potassium. So I'm going to go around that.
I mean, that was a pretty complete list. Those kind of things are actually readily available with the Google search. So, you know, in case we misspoke, you know, check. But we can try it with one more.
Don't forget the licorice as well. People who like to eat a lot of licorice, that's another factor.
Yeah, the glycerolinic acid in true licorice, not Twizzlers, but real licorice will knock you down if you're hypo.
Is it beneficial for me to take creatine, and how does that affect my potassium levels?
Actually, I don't know, but I don't think it is beneficial. I have no personal experience with that, but I don't think it's beneficial.
Deborah recommends it. Deborah recommends it. Deborah, who's giving?
Deb mentioned it. Yes, I mean, I guess it's anecdotal, you know. I don't see a harm in taking it, but I don't know that it's going to be favorable. You know, it's one of those things that you can try, always with the advisement of your physician. You have to have someone who's backing you up when you're trying new things and monitoring you. You know, certainly we're giving information here at the conference, but it's not, you know, we're not your personal physicians. It's more of an informational kind of thing here.
One that a lot of people asked, actually, they said Dr. Lamenhorn has their blood, and they want to know, are they going to be notified if something's identified, or how does that work?
Yes, you're going to be notified if something is found. You're also going to be getting a letter, you should have already gotten one, if they haven't found anything, asking you to send more medical records and more blood from various family members.
Dr. Siegel wanted me to mention that the owner's manual for the Hypo PP is on the PPA website. If you have trouble finding that, just email me and I can send you a link. They're also, he wanted to, is Dr. Siegel here? Oh, you're right here, yeah. Your Simul Consult website?
Two things I wanted to mention. One is that two people came and asked for the website for the diagnostic software that the doctors can use for free. So that's at, the address for that is simulconsult.com, simulconsult.com. So if you want your doctor to be able to use it, there's 6,000 doctors in 100 countries using it. I should mention, just for full disclosure, that I was the founder of the company. But the NIH links various stuff to us, and they've supported the efforts very generously, so I think your doctors will find this very credible. The second thing I wanted to mention is sort of this fantasy that I have of going through Sigmund Freud's book called Studies on Hysteria. And and seeing if there's if we can find any of the cases that look like they're actually periodic paralysis. And I got the book and I started reading through it, but it's a long book, and if anybody else wants to help in this, my fantasy is that we'll find one that really looks like periodic paralysis and then publish it as a paper of, hey, maybe he really missed this one. And it would be a lot of fun to do if we could find it. Of course, there is a real thing of conversion disorder. It's just that it's so tragic that so many of you have gotten accused of having it when in fact you have periodic paralysis, but it would get a lot of publicity for this issue if we could find something in Freud's original book that really looked like periodic paralysis. There may just not be enough details to do it, but we'll try. Let me just introduce one other thing that Frank Weber had a question before, was asked about the clotting disorder, and until we sorted out what the drug names and so forth, he has something to add about an alternative treatment that's used in Germany.
We have told about that personal basis here in the break. Another solution would be just to replace the missing clotting factor, and so you do not need the vasopressin.
Great. So instead of administering vasopressin in Germany, sometimes they will administer the missing clotting factor and avoid using that drug. Okay, now Shelley had wanted me to have group photos. So the question is, we have like a half hour.
Okay. First question is, various types of exercises have different effects on me. The skeletal muscles of the limbs cause weakness and provoke attacks, but when I work my core muscles, they respond well to exercise. So is this due to a difference between the different slow versus fast twitch type muscle fibers? And is there a way I can focus on the appropriate muscle fibers throughout the body to rebuild my strength without causing an attack?
Oh, yeah. So that's a very interesting question, and the simple answer is I don't know, actually. I mean, every skeletal muscle fibre has the defective channel, so it's not that it's just present in one type of fibre, be it fast twitch or slow twitch. I mean, I think in general, it's difficult to make recommendations about this, I think. I mean, I think core strengthening exercises would be helpful. And it's an interesting idea for a research project to see if there's any difference between different fibre types as to whether they are more susceptible to paralysis or not. So maybe that's one to file away and to have a think about. I'm sorry, I can't give you a more specific answer than that.
Then I mean, one other thing, just from a practical standpoint, if someone finds that they do exercise with one muscle and they get paralyzed, but exercise with a different muscle and they do well, so I don't see what's wrong with just doing exercise with the core and leaving alone the extremities. But that's just you have to survive somehow.
I think that does depend on the fact that the muscles are not affected in the same amount. You see, in paralysis, the extremity muscles of the extremities are affected more than the truncal muscles, and this is mirrored in the complaints we hear in this question. So, do everything of exercise which you can do, but not more. That would be the practical answer.
I wanted to draw a contrast to one of the usual rules that you'll hear about exercise of no pain, no gain. That's the absolute wrong approach for periodic paralysis. I would be closer to saying no pain, no permanent muscle damage. The idea would be to exercise, but stop at the point that it would cause pain, because that's probably associated with permanent muscle damage. So it may be you could, as the others explained, you could do more core than skeletal muscle exercise.
Dr. Cleland, you mentioned that a negative result of a long exercise test could be due to medication. How long should the patient be without medication before they repeat the test?
Yeah, so the general rule is sort of 5 half-lives, and I would say generally give it a week. It's not a test that needs to be done urgently, so if you can be off the medication for a week, that will be pretty much ensured that it's out of your system.
Does the diagnosis of hypo-PP require lower than normal potassium, or is it the idea that it's a shift from, for example, 4.2 to 3.6, so it's within normal limits, but still a decrease in potassium?
In my point of view, you do not need really low serum potassium level. Decisive are two things: the shift and that you have a positive response on potassium intake in or during the attack. That's the main thing, I think.
Yeah, I agreed. I think that a diagnosis of periodic paralysis is never just one thing. It's a complement of findings and things. So, yeah.
I wanted to add that my understanding is that everybody's potassium level fluctuates. The potassium level of someone who doesn't have periodic paralysis fluctuates as much as it does in somebody who has periodic paralysis, except when you get into an episode where the muscles start swelling, and then you have a drop in potassium because the muscles are taking up potassium. So the difference between somebody with hypokalemic periodic paralysis and someone who doesn't have any periodic paralysis is that they both have the fluctuations, but the person with the periodic paralysis gets into trouble during the fluctuation and the other person does not.
So I understand that we can share our genetic information on 23andMe with Dr. Lehman Horn. What will he do with this information? And beyond looking for lidocaine-resistant periodic paralysis, is there more genetic research going on for those with no known mutation?
Yes, of course. He looks for yet unknown and unidentified mutations. That's the main thing. And of course, he looks for mutations that are already identified. But the main thing is to look for yet unidentified new mutations.
And I'd like to add that if currently we can explain 70% of people with either a sodium or calcium channel mutation, if we get that up to 85 by finding the one for the lidocaine form, that will make it easier to find the mutations for the remaining 15%. So if you don't fit one of these groups, it doesn't say don't get involved. It says that it'll be easier once we knock off the next big one and get the percent that we can identify up to 85 from 70%.
I have suspected ATS, and my brother has rapid onset type 1 diabetes at age 21, and his son has been diagnosed with nephrotic syndrome at 10 years old. Could any of these conditions be related?
So for those of you who are not familiar with nephrotic syndrome, it's a kidney condition where you develop fluid retention. I would say that is, I've not seen that with any sort of muscle channelopathy. I don't know the cause of the nephrotic syndrome, but I think I would say that it's not related to the channelopathy, in this case ATS. Whether it's related to the diabetes, probably not, given that the diabetes developed way after the nephrotic syndrome. But I'm afraid I don't know the cause for that person's diabetes and nephrotic syndrome.
I should add that lots of people have other things that make their periodic paralysis better or worse. So often people who will have some sort of digestive problem will have more symptoms of periodic paralysis because they tend to be losing potassium. in their gut due to some other thing that they have that just makes it so they're more likely to be low in potassium. So similarly with some of the kidney diseases, you can have changes in sodium or calcium that might make you more symptomatic than somebody who had the periodic paralysis and didn't have the nephrotic syndrome. There's also long been recognized some interesting parallels between diabetes and periodic paralysis, in the sense that if you have periodic paralysis, you will basically want to eat as if you have diabetes. We have a faculty member, university faculty member, who's not a physician in the audience here, who's been looking into some of this beyond what I think people have looked into in general. I don't know if you want to come up and say something, or just for us to say that this is an interesting area that deserves some research, and that there's some intriguing possibilities that people are looking at.
Yeah, I think, Alan, you've mentioned that you have outlined a lot of your stuff on Deb's list. So maybe we can look into that later. I just want to make sure we address these other questions. So the next one.
I was told repeatedly by a dermatologist that a topical anesthetic used while taking off a small wart wouldn't cause me any problems. However, for the rest of the day I was weak. How do you tell a doctor about periodic paralysis and anesthesia in such a way that they believe you, but don't scare them so that they won't treat you?
Look, at the end of the day, you got to hope that your physician has an open mind, and if he doesn't have an open mind, you have to get another physician. But you should be, you should be able to tell your doctor. People tell me all the time I can't have epinephrine, and then I just use lidocaine only, and some people say that I can't use anything, and we find a way. So yeah, I don't know what to say about that.
So there's two key things about local anesthetics, and they're sort of opposite. So it'll be a little complicated, not only us, but to the doctors who won't know about this. So as Jake mentioned, if you have periodic paralysis, you need to mention to your doctor that to use lidocaine without epinephrine instead of lidocaine with epinephrine. They add epinephrine because it keeps the lidocaine local and makes it much more of a local process. So lidocaine is local for two reasons. One is you inject it locally, and the other is that they typically have epinephrine in, which shuts down some of the blood vessels and keeps it local. So it's important to explain that the epinephrine is a problem. They have lidocaine without epinephrine and can use it. Then there's the other thing, which makes it even more complicated, that some people don't even the lidocaine doesn't work for them. And you need to say some of the other lidocaine-like drugs do work, and they sort of typically know, oh, I have this stronger one, and so forth, and that they could use that. So there's two different issues with lidocaine. One is the epinephrine that can trigger attacks, and one is lidocaine doesn't work for some people. So it's complicated, and most of your doctors won't know about it. You'll have to tell them.
Thank you. We'll do that. We got 5 questions and 5 minutes.
Okay. My type of periodic paralysis is still unknown. If there's a history of sucks and anesthesia problems, does that indicate hyper-periodic paralysis rather than hypo? And what precautions should I take?
If you have a history with halogenated cases and with succinylmethonium, this is a hint that it could be hyper PP or something with myotonia. And I only thing I can suggest is a thorough evaluation. But sucks and halogenated gases, when they cause problems, this is a hint for myotonia or for hyper.
And also, Frank, how far into the family or extended family should precautions be taken if you don't know whether or not people are affected?
Well, if you do not know whether they are affected or not, you have to examine them to see whether they are affected or not. For example, if you have a strong index of suspicion for hyper-PP, you should do ordinary EMG, because with ordinary needle EMG, you can, with a reasonable amount of sensitivity, identify subclinical myotonia, and so you are quite sure whether this person is affected or not.
So basically, it prompts a more rigorous kind of search and workup.
I'm wondering about a possible connection between hypokalemic periodic paralysis and hyperflexible joints. Both my daughter and I have HKPP and very loose joints. I'm currently being evaluated for Ehlers-Danlos syndrome.
So I'll take that one. There are two things that could be going on. One, there could be a true genetic connection between hypermobility and periodic paralysis, and I could argue that I'm hypermobile a little bit. Deb Grant, when we were at our first conference, we talked about it. I mean, a number of people will raise their hands and say they're hypermobile. The other explanation could be that if we have some baseline fixed or weakness, that our muscles are not holding our joints and tendons and ligaments together quite as strongly as a normal person, and that may explain some hyperextensibility. I think that there's been no proof yet about any of this. It's something that we can keep in the back of our mind. So, I don't know that there's any definite relationship there, but it's definitely a hypothesis-generating question.
I have low titer positive voltage-gated potassium channel antibodies over several years. What? And no other evidence of myasthenia gravis, no enlarged thymus, periodic paralysis type diagnosis, along with other family who don't have these antibodies. Have you seen this, or can you explain the implication of these antibodies? No known periodic paralysis mutation, but a positive McManus.
Yeah, so this is a very interesting question. So there's a whole another set of rare diseases which we are learning more about, which are the autoimmune channelopathies. And so voltage-gated potassium channel antibodies is one of the first of these to be discovered. So they are channelopathies, but they're due to an autoimmune condition. So they're not inherited in the usual way that periodic paralysis is. They do cause muscular symptoms, usually some stiffness, not weakness, and they often cause central nervous system symptoms. So this would be loss of memory, confusion, these sorts of things. And I must say, some alarm bells have gone off from what people have described to me in the audience, that maybe there is a link there, that we should be looking for these antibodies more in some of you folks, especially those who are genetically negative. So there's no direct link between the two that we know of. The positive McManus test is a very interesting one, and we do know that some people that have voltage-gated potassium antibodies do have EMG abnormalities. I've not seen a positive McManus test with that, but they certainly do have EMG abnormalities. They'll have very high-frequency discharges that can look a bit like myotonia. So maybe there is more to the story than meets the eye with that.
I would add, just in terms of an empiric therapy, I deal with blistering diseases, pemphigus vulgaris and bullous pemphigoid, and those are autoantibodies to the skin, which makes blisters. And we commonly use IVIG, intravenous immune globulin, to decrease the bad antibody levels in the blood. And we also give something called rituximab, which it destroys the B cells that make bad antibodies. So if there's a really true link between bad antibodies and disease, those are some things that could be considered with obviously with your physician. No one can get that in the drugstore. Next question. Last question.
This is the last question. The closer I get to 100, the more resilient to stressors I am, until a multitude of stressors, like a virus and emotional stress with poor nutrition altogether, can put me right back down to 0. Does this make sense to anyone else?
Audience participation. I mean, getting close to 100, does that mean that you're 98, or does that mean that you're 40 going on? We're all getting closer to 100 at some point. The more resilient to stressors I am until multiple stressors put me back down to zero. Oh! I feel very silly. I guess some patients will experience that when they're good, and they're really good for a while, and they have a kind of equilibrium of good, they can tolerate a single insult here and not get a problem, a single insult there and not get a problem. But when you have like double and triple insults, you do exercise, you eat badly, you don't sleep well, and you have stress, bam, it takes a lot to take you down. I've certainly anecdotally found that to be the case. So it makes sense to me, I kind of relate to that once we take away the age issue. I guess we'll leave it at that. If we didn't get the question quite right, please, I'll encourage you to resubmit that one to PPA Ask the Experts. Okay, I think we've done, let's say that we're officially done with the informational part of the conference.